Hi, everyone. I'm Jeff Allen. I'm at the University of Minnesota, and it's my pleasure and honor to chat with you today about some emerging treatments, some standard of care for some of the diseases that are of interest to us, CIDP, multifocal motor neuropathy, and Guillain-Barré syndrome. It's a really exciting time to be part of these diseases, so I'm really pleased to be able to share some updates in this treatment space. Of course, for all of us, it can't move fast enough. We'd all like to see treatments come on board, more treatment options, evidence-based treatment options, safe treatment options. We'd like to see this field move faster and faster and faster. And it seems like it's moving always too slow. But I'm here to tell you that really behind the scenes and really, up front now, there's a lot of activity, and it's really exciting to be able to share it with you. If you just kind of take a look at what's being published in this space, if you look at publications from CIDP, GBS, and you look at it over the years, you can really see a massive growth in the amount of publications for these diseases. It seems to get more and more every year. If we put multifocal motor neuropathy on this list, you'd see the same thing. Of course, this doesn't always translate into treatments that are available to us, but just the excitement in the publications, I think, speaks volumes about what's really happening on the treatment space. So let's talk about some of those treatments. What do we know in 2024? What might we look forward to over the next couple of years? Standard of care treatments, I'm not going to spend a lot of time talking about this. Many of you all already know what's kind of available for you already, but in the case of CIDP, we know IVIG is effective. We know steroids work in some patients. We know that subcutaneous IG is helpful for prevention of relapse or maintenance. We've known about those interventions for CIDP for some time. For multifocal motor neuropathy, we know that IVIG is effective. Fortunately, beyond IVIG, there are no proven effective therapies for MMA. And in the case of Guillain-Barré syndrome, we know that IVIG and plasma exchange seem to be effective or helpful for that condition. So those are things that we know. However, there's a lot we still don't know about the scene. What's the best dose of some of these treatments? What's the best frequency? What happens when we combine things like IVIG and steroids together? Are there other medications that can be used as IVIG sparing options? And really how to personalize those treatments, individualize them for individual patient needs. A lot to learn on that end. Now, over the last 10 years or so, there's been a few studies that are of interest that I'm going to briefly point out because they've helped inform some of those decisions. These are all completed trials. There was a trial that was published a couple of years ago by Max Adrichem, that really tried to get to the bottom of how often we treat with IVIG, and maybe we don't always need it. We know that about 30 to 40% of the time people are on IVIG with CIDP, and maybe they could use less IVIG, maybe they couldn't use it and don't need it at all. And this trial, the IOC trial, put some numbers behind that, suggesting that we really have to kind of keep an open mind about the way we think about treating CIDP and trying to get the dose right with IVIG, and maybe at times trying to back off of it to see if we need it at all. There was another study that Dr. Kornblath published recently, that looked at some of the dosing parameters of IVIG and showed that in some people, our standard dose of IVIG works just fine, but there might be a smaller group of people that might do better if we really push the dose of IVIG up a little bit higher. So that was an important message to learn. Krista Kudward published a paper a few years ago that looked at the dose and the frequency of IVIG. Some people get to smaller doses more frequent, some larger doses less frequent, and she tried to put some color behind that and really showed that dosing within certain parameters that we usually every 2, 3, or 4 weeks, getting the dose right and the frequency right, we can customize that to individual patients. And then we looked at a study a couple of years ago called the Gripper study, where we really tried to quantify some of the changes that people experience in between IVIG treatments, and found that if we really pay attention to that, we can maybe minimize some of those fluctuations in between treatments. So we know some information about steroids, IVIG, and subcutaneous IG, but where do we go from here? What does the future look like? And that's what I'm going to spend the rest of our time talking about, future treatments, or at least treatments that are relatively new on the scene. The first one I'll talk about is this trial. This is called the ADVANCE trial, or the ADVANCE-1 and the ADVANCE-3 trial. This trial was completed recently and published in 2023. And it's looking at a treatment for CIDP called facilitated subcutaneous IG. Most of you are familiar with subcutaneous IG. It's immunoglobulin that instead of putting it through a vein, you put it in through your fat, through the subcutaneous tissue. This is a little bit different because it takes subcutaneous IG and it combines it with a compound called hyaluronidase. Now, hyaluron is a compound that lives in the subcutaneous tissue, and it essentially purpose is to prevent the diffusion of anything that penetrates into the subcutaneous tissue, which makes sense. If you have something that penetrates in there, you don't want it to diffuse to the other tissues or vasculature or other structures. But what that also limits us is the amount of fluid that we can put in the subcutaneous tissue. In the case of subcutaneous IG, it limits how much drug we can put in there. So HyQvia is a combination of hyaluronidase plus immunoglobulin, and the hyaluronidase essentially unlocks the subcutaneous tissues. And so instead of putting a small amount of immunoglobulin in at one time, you can put a very large amount of immunoglobulin in at one time. And clinically, what that means is that instead of getting a small dose of subcutaneous IG once per week, or more often than that, you can get a larger dose of subcutaneous IG potentially every 3 or 4 weeks, similar to the way we dose IVIG. And that's what this study, the advanced study, showed. Patients in the study, which was a phase 3 study, were all coming in on IVIG. Essentially, they were randomized to either facilitated IG or to placebo. They were followed over 6 months, and the relapse rates in both groups were evaluated. And what was shown is that patients that were treated with the facilitated IG, so sub-Q IG plus hyaluronidase, had a far lower relapse rate than those that were on placebo, demonstrating that this was effective for prevention of relapse in patients with subcutaneous IG. Most of the patients that were on this subcutaneous treatment got an infusion subcutaneously once per month, usually required about 2 hours to do it, and usually about 2 needle sticks to go in. So maybe a new option for those that are interested in subcutaneous IG, balancing things that are important to you, something to maybe talk to your doctor about, a new way to administer subcutaneous IG. The next class of drugs I want to talk about are the FcRn antagonists, which is really an exciting class of interventions that's really new to the scene, really within the last 10 years or so. So what is an FcR antagonist? The FcR receptor is a receptor that lives in a cell called endothelial cells, and these cells sort of line blood vessels. And this receptor is kind of the gateway receptor to determine what sort of proteins are friendly and should be recirculated into the vasculature and what needs to be destroyed. So as proteins or immunoglobulins float down the vasculature, they get taken up by these cells, and they're going to try to bind this FcR receptor. And if you can bind this receptor, then you get kicked back out into the circulation. And if you fail to bind the receptor, then you get destroyed. You get catabolized by that cell. So what an FcRn receptor does is it comes in and blocks all of those receptors. So if you block those receptors, then all of these immunoglobulins that are floating through the vasculature can't bind to the receptor. And if it can't bind to the receptor, then it can't go back out into the circulation, and it's destroyed by the body. So what that means is that any protein or antibody that's causing damage, instead of being kicked back out into the circulation, which can continue to cause mischief, now can get destroyed. Now it also diminishes normal IgG levels, normal immunoglobulin levels, since those are also mediated by this receptor. So you drop those receptors. But the idea here is that if there are antibodies that are causing disease, then blocking this receptor will cause the body or result in the body of eliminating these antibodies. So over the last 6-7 years, there have been 4 clinical trials that have been interested in investigating this mechanism, which is quite a few trials. The first one that came on was a small study which investigated a drug called Rituximab. The study was small. It was probably underpowered to find a big treatment effect, and the study was aborted after a small number of patients were enrolled because no treatment benefit was seen in the number of patients that were included. Since then, though, there's been 3 other trials that are larger and that are either ongoing or completed. One is batoclimab from a company called Immunovant. The other is nipocalimab for a company called Janssen. And the one that I'll talk the most about, because we have results, is efgartigimod from a company called argenx. I'll point out that these other two trials, the Immunovant and the Johnson trial, are still enrolling. I encourage you to go to clinicaltrials.gov, where you can see a complete list of enrolling sites to see if there might be a site that's close or convenient for you, if the trial would be a good fit for you, and that's something that you're interested in. So let's spend a little time talking about efgartigimod in the argenx trial. So this is studying a drug called Vyvgart for the treatment of CIDP. This is a phase 2 trial. It's a fairly complicated trial, but essentially people had to show that they had real disease, and then asked to, if you were on standard of care treatments like IVIG, stop your treatments to show some worsening. And then if you worsened, then you were put on open label Vyvgart to look for an improvement in your condition. And then if you improved, then you were randomized to either continued treatment with the medication or to a placebo, followed for a period of time, and then looking at a relapse rate within 48 weeks. So the study found that of patients that were put on study drug, about 67% improved when it was open label. So everybody got the treatment. More than 2/3 of people benefited from the treatment. And then in the placebo-controlled phase, roughly 74% of patients did not relapse, so stable during that treatment phase. And that resulted in a 61% reduction of relapse during that randomized placebo-controlled phase. So this study is now demonstrated improvement in Vyvgart for the treatment of CIDP and prevention of relapse during the maintenance phase. And on the basis of the trial, this drug now has an FDA indication for the treatment of CIDP. So an exciting new potential treatment option for patients. From a logistic standpoint, it has some things that are quite desirable. It's a subcutaneous injection. It takes about 1 to 2 minutes to do. And it's administered once weekly. At this time, it's required that a healthcare provider administer the medication once weekly. So it's maybe potentially something to talk to your doctor about, but remember those other two trials are still ongoing. So we'll look forward to those results over the next couple of years. So how about Rituximab? So Rituximab is a drug that many people are familiar with. We've used it off-label for the treatment of CIDP for a number of years. Some people have found it quite beneficial, others not so much. But there's been a couple of clinical trials that are ongoing or have recently been completed that have looked at Rituximab for treatment of CIDP. Rituximab is an immunosuppressant medication, and it essentially blocks a particular type of B cell that carries a CD20 marker. So it drops these B cells quite robustly and quite quickly over a durable period of up to 6 months or more for some patients. So 2 studies are looking at Rituximab for treatment of CIDP. One is a Japanese study, the other is an Italian study. The design of them both is that you're treated with Rituximab for a period of time, and then in the case of the Italian study, a retreatment at 6 months, and then the main outcome is a year after the study starts, or 6 months after you stop your last Rituximab, and you're looking at patients that improve and patients that are off their treatment and don't relapse. This Japanese study is a smaller study. The Italian study is a bit of a larger study. Now, the Italian study actually released their results within the last few months. Unfortunately, what they found is that the relapse rates at 12 months in both the patients that were on placebo and Rituximab were similar. Those that were treated with Rituximab seemed to have a longer time to relapse than those on placebo, but the end result was the same. So I think even based on these trials, we've still got some things to learn about what's the role of Rituximab in CIDP. And based on the Italian study, it seems not to be a treatment for everybody. Perhaps if we can learn more about it, we can understand if there's a group of patients within the CIDP community that might be good candidates for this, or maybe the study tells us that there's a benefit to the drug, but the way we conventionally use it is not quite right. So we'll look forward to the results of both of these trials in published format, but it's exciting to see some data around Rituximab, because it is a drug we use not uncommonly in the CIDP space. Next group of drugs are those that attack the so-called complement immune system. So complement is something that we know is now important for CIDP, for multifocal motor neuropathy, and also for Guillain-Barré syndrome. And it's part of the immune system that, when activated, is responsible for a lot of inflammation and damage to whatever is being told to damage. So if the complement system is, for example, targeted against a foreign bacteria or a virus, comes in and tries to destroy that foreign virus. If there's some debris or tissue in the body that needs to be cleared because it's died for whatever reason, the complement system will come out and clear away that debris. So it's got a really important physiologic function. However, in the case of autoimmune diseases, what happens is that the body turns the complement, this attack mechanism, onto something that's friendly, and then the complement system tries to destroy it. So the idea here is if you block this complement part of the immune system, you can still have maybe an abnormal immune response in the background, but you're kind of shielding that structure from the cavalry, from the infantry that's trying to damage whatever structure is being damaged by the complement system, in this case, the peripheral nerve. So blocking complement is something that's kind of a hot topic in many neurologic diseases, including those with inflammatory neuropathy. So we've got a couple of trials to talk about that are investigating complement. The first are CIDP trials. This first trial that I'm going to talk about is one from a company called Sanofi, and they've got a drug called Rituximab. They completed a phase 2 trial, which was an open-label trial of Rituximab for the treatment of CIDP. And they approached it a little bit different than what we saw in those FcRn trials, where in this trial, the group looked really at different populations of patients with CIDP. They looked at patients that were on standard treatments and doing okay, they were stable. They also looked at a separate population of patients that maybe were not doing okay with standard of treatment. So you get IVIG, you get corticosteroids, doesn't really help. What's the role of complement in those? So this drug looked at that group separately, and then also people that had not been exposed to any treatment thus far, so-called treatment naive group. So a couple of different groups. So patients within these groups were put on open label, so everybody got the treatment of Rituximab, followed for 52 weeks, and looked at response rates and relapse rates depending on which group you were in. And the results were pretty exciting. So these phase 2 open label results showed that people that were on standard of care, 87% of folks in that group either were improved during that 52-week period, and some patients actually got better compared to where they were at for their standard of care. A very interesting result. Of the patients that were refractory, so they didn't seem to respond to standard treatments, about half of those folks actually showed some improvement with Rituximab. And of the treatment-naive patients, a good percent of those people had improvements and sustained improvements up to 71% at a year. So it's a phase 2 trial, it's open label. There's a lot we still have to learn about these studies, but it's pretty exciting results showing that some people, at least based on the results shown here, are stable, maybe even improved from standard of care, although there's a big maybe with the way this study was designed. But it's still exciting. And on the basis of this trial, we've got 2 phase 3 more definitive trials that are coming that Sanofi is developing. These trials go by the names of the Mobilize trial, which is designed for that group of patients that are refractory or have inadequate responses to treatment with standard of care, and another trial called the Vitalize trial, which is designed for people that are on stable maintenance therapy with standard of care like IVIG. So again, clinicaltrials.gov, take a look at these trials. Enrollment's probably going to start this year or next, and it'll be exciting to see what we find in a bigger, more definitive trial. To see if those exciting phase 2 results can be replicated in a more definitive phase 3 randomized placebo-controlled trial. All right, shifting gears a little bit, let's talk about multifocal motor neuropathy, but stick with the same theme of complement. There's this trial that was recently completed in multifocal motor neuropathy. It's called the ARTA trial. This was done by argenx, and their drug that they have is called empasiprubart. This was a phase 2 trial in people with MMN. And essentially what happened in this trial is that you had to have MMN, you had to be on standard of care with IVIG, you were followed on your standard of care for a period of time, and then you were randomized to either the study drug, empasiprubart, or to placebo, and then you were followed for up to 52 weeks, and then we were looking for relapse rates. So how often did you relapse during that period if you were on empasiprubart or if you were on placebo? Some of these results were also recently recently released, and it was shown that compared to people that were given the placebo, those on empasiprubart had a reduced risk of relapse by 91%, which is a pretty striking result, considering that for a multifocal motor neuropathy, no treatment other than IVIG has been shown to be effective. So it really speaks to the value of complement inhibition in this group of patients. It was also noted in that phase 2 trial that patients that were treated with empasiprubart, some of those patients had improved strength and improved disability or less disability compared to when they were on their standards of care. So again, this is a phase 2 trial. We need to learn about this in more detail, but really exciting results for folks with multifocal motor neuropathy. And on the basis of these phase 2 trial, a global, larger phase 3 study that's looking at empasiprubart in adults with multifocal motor neuropathy is in the planning stages. So keep an eye, again, on clinicaltrials.gov to understand enrolling sites and when we might expect to see this trial. And now turning our attention to Guillain-Barré syndrome, but again, sticking with complement. It's complement, it's really a hot button for a lot of these just different diseases, and GBS is no exception. So complement, was studied by a group called Annexon, a company called Annexon, and they've got a complement inhibitor which doesn't have a difficult to pronounce name yet, but it will, I'm sure, at some point. But that compound right now goes by the name of ANX005. And what they did was look at this clinical trial for patients with GBS in Bangladesh in order to understand what the benefit of early complement inhibition is in Guillain-Barré syndrome. So this was a trial that was placebo-controlled trials. So patients with GBS were randomized to either placebo or to their complement inhibitor drug. The trial was largely performed in Bangladesh. And the reason for that is that Bangladesh is a very, very sophisticated network of GBS. They see a lot of GBS. They really know how to take care of it, and they can really centralize the patients with that to a center that's really an expert in treating GBS. So it was a really high quality trial of folks with GBS. So patients were randomized to either placebo or to the complement inhibitor. They were followed over a period of time. And essentially some of the important outcomes that we were looking at for the trial is, how long did it take you to get better, less disability? How long until your strength improved? How long were you on something like a ventilator? How long did it take for you to walk again? And the trial was really quite exciting in that it showed, compared to placebo, there was a 2.5-fold improvement of disability when assessed at 8 weeks. And other important secondary outcome measures like improvement in strength, time on a ventilator, and time to walk all were strongly in favor of treatment with the ANX005 compared to placebo. So it really presents a strong case where early intervention with a complement inhibitor gets people better faster. We've got to learn more about this drug, understand what the value is relative to some of our current standard of cares, including IVIG. But it's really exciting to see a new mechanism come on that really convincingly shows benefit in this treatment space. The final thing that I'll talk about is maybe just some uncertainties in general with the field. And so you may be familiar with a recently published CIDP guideline in 2021 that really tried to better define what the disease is. There is a wide spectrum of the disease. We know that it's a syndrome now. It's got different ways that it presents, different clinical features that it presents with. And we still sometimes struggle defining what the true boundaries of this disease is. And so for that reason, many of us have tried to understand, is there a way that we can better define this very rare disease, which is tricky because it's a rare disease. And so the ability of an individual clinician or even a country, a couple of centers to really capture the true spectrum of the disease is really quite challenging. And so for those reasons, some of us have put together this CIDP registry which we now call INKbase. And the idea with INKbase is that it is designed to capture a uniform set of clinical and potentially biological information about people with CIDP and follow that prospectively over time. So it's a study that was launched in 2020 and 2021 and has really ramped up enrollment over the last couple of years, and we can expect it to continue to ramp up enrollment over the next couple of years. This is not an investigational study, so nobody gets a drug or a compound with this study. It's just a way to follow CIDP prospectively to really understand what the disease is and try to really understand what we don't know about the disease, capture the full spectrum of the disease. There's a number of sites that are currently enrolling in the United States. Many of those are central and eastern, although I'm hoping to bring some sites also to the western part of the United States. So if it's something that you're interested in and you're in one of these areas, it might be worth talking to your local doctors to see if it's something we might participate in. It's also a study that we hope someday to branch out to other related disease spaces, including multifocal motor neuropathy, although we're not there quite yet. It is a global study, and so there's a lot of participating centers throughout the globe. The idea here is that we can work together, we can really capture everybody with this disease to really understand the full spectrum of the disease, not just the small little groups of patients that we might see at our local center. So thank you for your listening, your willingness to participate. Of course, a huge thank you to the GBS-CIDP Foundation. We couldn't do much of this work, without them. Thank you to our industry partners. I mentioned a number of them here. Working together is really the key to understand some of these challenging rare diseases and how to study them, how to bring them treatments. And most of all, thank you for all of you that are affected by this disease and your loved ones. Certainly we couldn't do any of this without you. So thank you for your support and your partnership.